and Petros go way back, my understanding is, right? Way back. They've been collaborators, so they are here to tell us about themselves, their achievement, and the collaboration in the context of the newborn genome screening. So before doing that, I just want to say a few words for the people that do not know that newborn screening really for genetic disorder is not a new thing, right? So at least in the UK, it's been around for over 50 years, and correct me if I'm wrong, even for phenylketonuria, we are talking the 1930s even. But for the UK, so, and it's still now, there is this new, it's called newborn spot screening, with the use of dried blood spot Guthrie card. So this has been around for 50 years. It's still available in the NHS, but it only tests 9 diseases, 7 of which are inherited metabolic diseases. So nowadays with whole genome sequencing, as you know, we are able to sequence the whole genome. Right? So with this comes challenges, of course, and we are here to talk about the advantages, challenges of this new method of newborn screening, let's say. Ethical, we'll hear from the panel around maybe consent, but also very important issues and challenges around data. Right, data integrity, data sharing, data security. So today with our guests, we'll hear all the amazing work in Greece and in England with Genomics England, and also trying to understand how federation, that we just heard from Pablo, how really data federation can play an important role in responsible data sharing, which is so important. So now, before I pass it on, after the introduction and a few questions, I will invite all of you, please, to ask as many questions, because we have really the most important people in this area and space here. So please take advantage of this and ask as many questions as you wish. So, and with further ado, David, maybe I'll start with you since you are on my left. Great. To just introduce yourself and tell us all the amazing things that you're doing in Genomics England.
Great. Well,
thank you.
Well, first of all, I want to thank LifeBit and Kara for inviting us to talk a little bit about newborn screening using genomics. My background is I practiced clinical genetics in the States for about 30 years and also ran whole genome sequencing clinical labs in the States for more than 10 years and joined Genomics England 2 years ago to work on the newborn program. And I will say that in my entire career, this is probably the most interesting and probably the most impactful thing that I've gotten to be involved with. So if people from Genomics England are out there, please, I want to say thank you for inviting me to help. So the program is going to look at whole genome sequencing of newborns. The program is called the Generation Study. And I should make sure that everybody understands that Genomics England is part of the NHS. And as Augusto pointed out, it has 2 current main functions, which are to use genomics in the rare disease space in terms of diagnostics, but also in the cancer space in terms of diagnostics and treatment. We're moving on to adding newborn screening, as I'm going to talk about in a bit. So in 2019, Sally Davies, who was then the Chief Medical Officer for England, put together a group to ask the question, might it make sense to add whole genome sequencing as a screening test and adding that to the current newborn screen? And then in 2021, there was a large public engagement, and the public was invited to think about the question of using genomics in the newborn screening setting. And the message that came back was that there were really 2 aspects that the public was very interested in. Number one, they were interested in screening for conditions that are treatable. And the second thing is that treatable condition needed to have its treatment undertaken in the first few years of life. As important as it is to screen for, say, BRCA1 for hereditary cancer, the public was, at this point, mostly interested in what we could do to help newborns in the first few years of life who had treatable conditions. So, as was pointed out, at present in England, there are 9 conditions on the newborn screening panel. This program has been incredibly successful, like other newborn screening panels programs around the world, has extremely high uptake, extremely positive response from the public. And so, building on that, we want to make sure, or we want to explore, can we use whole genome sequencing as an adjunct to that screening? So why do whole genome sequencing? The current newborn screening is working well. We could add conditions. Well, it turns out that approximately 1 in 190 children are born every day with a treatable condition where there's a specific treatment. And in England, there's about 600,000 births. So that means that 9 children are born every day in England with a treatable condition. And so given the large number, and I'm going to talk about the number of treatable conditions that we're putting on this panel, the notion is, could we use this technology to broaden more quickly the number of conditions that could be gone after that are treatable? So the generation study really has 3 parts to it, and one is the obvious one, which is what is the utility and feasibility of genomics as a screening test? The second is a research opportunity. Can we use the information that we learn from these genomes, anonymized, obviously with parental permission? This is obviously a research study, to improve diagnostics, and most importantly, to improve therapeutics. And then the third part, which is a bit more speculative, is to ask the question, can we use the genome across the lifespan? A really important aspect of this, and I think that everyone really needs to keep this in mind, this program that we're carrying out is to ask the question whether we should do this at all. Is there enough evidence? Can we glean evidence from screening these 100,000 children? Can we glean enough evidence for this to make sense to be used long-term for all children in the NHS? And this is absolutely an open question. So I had mentioned that we're very interested in the question of utility, but there are other very important aspects that are also going to be studied from an evaluation point of view. What did the moms and dads think about this? What did the physicians think about this? Did they find that this was helpful, useful? And then very importantly, what are the economics of this? Does this make economic sense? Because the NHS is a national health service, a national health system, and so the cost issues are paramount. We're going to use whole genome sequencing, and people have asked me, like, why do that? And that's because by analyzing or obtaining a whole genome, you can look at any variant type, not only small changes like a point mutation, but you could also look at deletions or trinucleotide repeat diseases. Also, in our program, we anticipate over the course of the program to add conditions as more conditions are available for treatment on the NHS. And that's easy to do if you're using a whole genome. Researchers are very interested in this information, but they really want whole genomes to work with. They don't want to be working with exomes. And then finally, if we're going to think about using this across the lifespan, then a genome is the logical place to go. And so for all of those reasons, the program is being established using whole genome sequencing. We'll be recruiting patients during pregnancy. We're going to ask midwives to speak to families in mid-trimester. And then at birth, we're going to take cord blood. It turns out that we've done some preliminary work, and it's very straightforward, it turns out, because midwives are taking cord blood for Rh disease anyway. It turns out it's very straightforward for them to do that, and so that's a very nice sample type. We're going to be starting with 5 trusts around England, and then moving up to 40 trusts, because in order to achieve that 100,000, we'd like to recruit 20,000 in the first year and 80,000 in the second year. How did we choose conditions to put on the list altogether? Well, this involved bringing together groups to think about principles. There are 4 principles, and we can talk about those later. Using these 4 principles for choosing conditions, we went to a long list of conditions to be considered from websites, from clinicians, and this allowed us to come up with a list which we then brought to the attention of specialists around England, and then finally the NHS itself, to make sure that the treatments were widely available. We started with 834 conditions. It turns out that at the present 834 genes, at the present time, we have 480 genes representing about 220 conditions. Remember that some conditions are caused by more than one gene. And so that's where we stand today. We plan to initiate the first recruitment in January. We're going to only be looking for pathogenic and likely pathogenic variants. And this is because of the problem of positive predictive value in an individual, a child who has no apparent phenotype for a rare disease. And we can go down that rabbit hole during the question and answer. And then the last part is going to be an advertisement. There is an international consortium of newborn sequencing. And if you go to your phones, you can look for this. We had our most recent meeting in England, and so if you're really interested in this topic, basically all of the groups around the world who are involved in using genomics as a newborn screen are part of this consortium. So with that, I will turn it back over to you.
Thank you, David. Very nice introduction to the topic. Petros, can I go to you?
Thank you, Chiara, and thank you thanks LifeBit for organizing this and inviting me to this event. I'm a clinical geneticist like David, and in fact, my entire professional life I've spent in 2 medical schools. One was the University of Connecticut, and the second one was Yale University. And that's where both of us have inhabited those buildings at different stages in our life. So I'll talk to you about first steps. And first steps is the Newborn Genome Screening Initiative in Greece. Obviously, my name and shows that I'm Greek, and although all my professional life I have never practiced medicine in Greece, I thought that Greece offered a few unique features and characteristics to try to leapfrog newborn screening from where it is right now to genome screening. So let's start with some basic facts which are important. Number one is about 1 in 20 babies are born with a rare disease, and about 80% of those babies have a genetic disease. So that's a fact that we should always keep in mind. So there are about 7,000 plus genetic diseases, and the number, of course, is increasing. And although some of those are very rare, on the aggregate, they account for a significant percentage of admissions to a children's hospital. David and I know the senior author of a paper from a few years back where they saw that about 35% of admissions to a children's hospital are triggered by an underlying genetic disease. So genetic disease is a real problem. So that's one part of the equation. The second part is we need to make a distinction, or at least genetic screening or newborn screening was introduced, at least in the United States, in the mid-60s. and everybody knows about the hugely successful story of phenylketonuria. And this has practically become the global standard of care in any country where there is an organized public health system. In Greece, it was introduced in 1974. I was a medical student at that time, and I do remember doing my rotation through the Children's Hospital where we started talking about it. And at this point, there are about 33 genetic disorders that are covered through newborn biochemical screening. And that brings the second important point that we need to make, is that the current technology for biochemical screening is based on tandem mass spectrometry. And it has reached, or it's reaching, the outer limits of the ability to predict or look at changes at genetic diseases. Okay, it's about 90 to 100, 100 maximum. So DNA sequencing or genomic screening allows to increase the number of conditions that can be screened, okay? And from the current level of up to 80, 90 to practically all genetic diseases that can be screened or detected. And so this is the strong case to make to you and to all others as to why we need to transition or to add newborn genome screening as a second layer of screening to what already exists. I hope you agree with that. So that's as a basic information to the group here. Now, what we decided to do in Greece is we want to introduce that, the first step study, to introduce it in phases. Obviously, our goal is to have newborn genome screening as a second layer of screening in Greece in 5 to 6 years. But this needs to be done in a way that establishes feasibility, acceptance, clinical utility, scalability, and of course, health economics. And so we are currently in phase 1 trial, which is through informed consent, and it's administered through 3 university hospitals in southern, central, and northern Greece. And our goal is to enroll up to 1,000 babies by the middle of 24. We are already in the 150 mark, and we have detected the first positive case. So phase 2 is to escalate and go to 20,000 babies, and there the goal is to establish a birth incidence of pathogenic and likely pathogenic variants, and also try to start a modeling as to what the actual cost is and how much money it would save the healthcare system in the country. Now, Greece is a small country. It's about 10 million. And it's actually quite diverse genetically. And by virtue of history and geography. And therefore, by doing a phase 2 trial to see what is the baseline of birth incidence, it will allow us to also identify the geographical distribution of variants, because healthcare delivery is not the same in different parts of the country. as you know, there is mainland Greece, and there is about 2,000 islands, of which only about 150 are inhabited. And they account for 5% of the population, and I'm not talking about the big islands like Crete. And we need to be aware as to whether or not there are pockets of mutations in those islands and how we could address those needs. So this is the purpose of staging it in phase 1, phase 2, and phase 3, a validation trial. And we expect that by 2027, we'll be in a position to make the data actually to allow the policymakers to make a rational decision, if it makes sense, to introduce newborn genome screening as a universal mandate in Greece. You heard from what you can surmise from what I say, that I consider newborn genome screening as a public good. Okay, it's something which needs to be given to the population in terms of, for a number of reasons. And I, as David, First Steps is part of the ICONS consortium, and we would like to see that this consortium increases. And as one of our colleagues, Stephen Kingsmore, says, let's set a goal of sequencing 1 million babies by 2030.
Amazing.
Thank you.
Amazing. Thank you so much, both of you. Maybe just a follow-up question, because you mentioned Greece and the differences between the island and mainland Greece. Coming back to the public consultation that happened in the UK, did you follow the same process in Greece? Was there a public consultation? And if not, what is the reception of this new initiative in the public perception? Yeah. And what are the challenges that you are finding there?
We did a number of focus groups. And so we saw that overwhelming, of course, focus groups is not necessarily the people who want to be heard. Okay, so we should not actually equate it to what the average person thinks. Okay, so from the focus groups we got that about 80 to 90% thought that they would like to see that. They would like their children to be having this test. Okay. And of course, these were women who were pregnant and were going to deliver in the next 3 months, and women who had given birth 6 months, up to 6 months. So that was the part that encouraged us that, yes, there is interest. And now that we are in the process of actually going to enrolling patients in the study, in the phase 1 trial, and of course it's informed consent, and it's a very a process that is quite regimented, let's put it this way. We see that about 80 to 90% of women, and I say 80 to 90 because each of the sites has a different range. When we go and talk to the parents, they say yes. So that, it's still a very small, it's early and it's a very small sample, but we find it encouraging that it's going to be societally acceptable.
Yeah, that's what.
That's the long answer to your question.
Yep, correct. Thank you so much. Question for you, David. You mentioned I believe, 4 criteria for choosing the genes and disease that are included in the screening. I'm interested because we hear a lot about actionable, non-actionable, and maybe you can explain to the audience what that means, and yeah, why certain diseases are there and not others, for example, maybe more specifically.
Right. So the question about gene selection has been very important to us. In 2022, we spent a good deal of time coming up with 4 principles, and we involved the public, we involved physicians, scientists, the NHS. And the 4 principles are the following, and you can actually find them online. If you go to the Genomics England website and you click on the part about newborn sequencing, our newborn program, you'll find the principles laid out there. But briefly, the first principle is that there has to be a well-established connection between the gene and the disorder. So the gene PAH is well connected to the disease phenylketonuria. So that's principle A. Principle B was that the condition needed to be severe, something very significant. It couldn't be a minor condition. I often like to use pyridoxine responsive epilepsy. Here's a condition where you have rather severe seizures. And so that's an example of a condition where the gene and the condition are well established, and it's a severe condition. Principle C is around treatment. There are, and I should, before I get finished with principle A, we generally want to have a confirmatory test, but it's not absolutely required for a gene to be on the panel. And we can go into that in some detail later. Principle C is really around treatment. Is there a treatment which will significantly alter the outcome for that child if it's initiated before symptoms start or very early in the appearance of symptoms, and that the treatment really needs to be initiated within the first 5 years of life? So those are the main features of Principle C. And then Principle D is around equity, that if you're in England and you're on the NHS, that the treatment is available across all of the NHS. It's not a research, it's not a clinical trial, it's a regularly accepted treatment. So those are really the 4 principles that are used for selecting conditions. And going into those, or looking at those, as I had alluded to before, it was really important that we engage with the physician community, the specialist community around those. But equally important, we engaged with what are called the clinical reference groups. Within the NHS, there are groups of physicians that are set up by the NHS who are there to sort of represent that community for that disorder, so that specialty. So for example, there's an endocrine CRG, and there's a nephrology CRG. And they really helped us not only think about the conditions, but connect us up with specialists who had a special interest in some particular disorder, say Alport syndrome, for example. So, and then beyond that, there was another group, the conditions assurance group, which was also part of the NHS, to sort of take those conditions, say, all right, we've had consultation with the specialists, now we're also going to consult with what are called the commissioners, and these are individuals who sort of hold the purse strings, if you will, at each of the trusts. A trust is sort of a hospital system, contains a bunch of hospitals, for them to confirm that that treatment really is available in all of the trusts. And then that's the process for, if you will, approving or choosing these conditions.
Very nice, so very equitable. That way that every patient could, yeah,
right.
Perfect. Moving on to data now. I mentioned in my introduction, we will talk about data and the challenges around data sharing. Obviously, this type of data not only is shared with the physician of the patient, the family, but also eventually for research, right? So again, what is one term that I've learned the other day talking to David was, written it down, is genetic exceptionalism. which I love the whole concept. So I would like maybe you to spend a few minutes on that. But what is that first, and why are we treating genetic data in a different manner in some cases? But also, what are, maybe you, Petros, what are the challenges with data sharing, data integrity, and all of that? Don't know who wants to start.
Two big topics.
Is my last question, and then I'll leave it to the audience.
I'll do exceptionalism, and you do everything else. So, one of the challenges in genetics has been this concept of genetic exceptionalism. For many years, folks were worried that somehow genetic information and genetic data were somehow very special and had to be treated in some very special way. And those of us who've been doing genetics for many, many years don't believe that. We think that a genetic test should be like every other test. Clinicians should use it in the way they normally use other clinical, other testing information for their patients. And so folks will say, well, doesn't genetic testing have wide implications for the family, and so don't you need to treat that more specially? Well, a cholesterol test, frankly, is a genetic test. Mm-hmm. If you have very high cholesterol, it wouldn't be unusual for your relatives to have that. And so we don't ever think about hypercholesterolemia as a genetic test, but in fact it is. And in terms of data protection, which Petros is going to talk some more about, genetic data should be protected in the way we protect other health data. For example, if a person has AIDS, I think HIV, I think their data should be protected. Or if you have some other non-genetic condition, I think that data should be protected. And so genetic exceptionalism, I believe, has gotten in the way of using genetics more broadly and including our colleagues and the public more widely.
I don't have much to add to that. I fully agree. It's the way that we should view genetic information is, and I think we heard a couple of very interesting talks this morning from Latin America. Okay. And I'm just jumping into the need to be outward-looking and federating information. Okay. The majority of, we have two challenges as I view them. The first challenge is that the data sets that have been generated so far are based on Northern European populations. And they might not be applicable to other populations. Southern European populations, African, Asian, Latin American populations. So that's one fact that we need to keep in mind. The second part, which is equally important, is that we talk about pathogenic and likely pathogenic variants. And these have been established in babies or individuals who have symptoms. So by definition, this is a high-risk group. Okay. What we're talking here right now is we're talking about a low-risk group. We're talking about forward prediction and positive predictive value of a variant. So the two challenges that we are facing right now is, number one, is genetic diversity, okay, and we need to be inclusive and improve on that. And the second part is we need to validate if a variant that we use, which was found in a sick baby, can also predict disease in a baby that is totally who is asymptomatic at the time when we do the test. So the best way to, or at least a rational way to address that is to be able to share information. And we need to also be cognizant of the fact that we operate in jurisdictions, okay, and we don't have a general data privacy policy everywhere the same, and also there are national policies. And so, to me, it looks like it is critical that we very quickly develop the approach, the method, the platform where we can all share while at the same time protect the information, the personal nature of the information, okay? Because like all other health information or personal information, we need to establish trust here. I mean, it's a much used word these days, but the reality is that if we lose trust from the people we want to help, serve, we are done,
yep.
in simple terms. So, first steps is outward looking, okay? We want to collaborate, we want to share information, and we want to contribute information. So it's a two-way street. By sharing information means that you benefit from it, but you also contribute so others benefit from it. And by the way, this is the fundamental point that the average citizen makes. If I can, the information that my baby, okay, is affected with can be used to help another baby, another family, then they're willing to do that. It's a deep altruistic feeling. Mm-hmm. And so to the extent that we can capitalize on that in a real way, okay, not that will come back and bite us, then this is the key answer to question of data sharing and data federation.
So technology like LiveBit, but others in data federation will help in these terms. Yeah. Okay, I'll stop here with my questions. So now the audience, are there any questions for David and Petros? Oh, okay. Who? Yeah, maybe James first. Mike. Kelly. Oh, we lost the mics.
Where is Torben?
Shout, come here.
Thank you, and thank you both, all three of you. I'm James Tsipouras, I'm from Genomics England. So, David, I understand from you, and we've spoken before about the community engagement that's happened. What I feel is very critical here, and I'd love to hear from Petros as well on this, is how you engage the community around the research side of a newborn program, newborn sequencing program. So what I mean by that is there's clear benefit to parents for finding out about a diagnosis, finding out about an intervention that can improve their baby's life. However, I see substantial reluctance from new parents in submitting their child's, their newborn baby, the most precious thing in their world, whole genome sequence into a program like this. We touched on genetic exceptionalism, and I think there is a lot of that. I think there is a lot of concern. So how is that addressed in these programs, and how should that be addressed more globally?
Yeah, I mean, you want to go first, or I can go? Yeah, so at Genomics England, when we went through the Research Ethics Committee, which is like the IRB in other countries, it's a research study. And so what we're going to ask parents to do when we speak to them in mid-trimester, we're going to say to them, look, the current newborn screening program is very successful, but we'd like to explore looking at a larger number of conditions. And we're going to use numbers like 200 conditions, which are currently not on the newborn screening panel. We're going to say, would you be interested potentially in becoming involved in us looking for this larger number of conditions? We don't think there's a high probability that your child will have one of these, but if they do have one of these and we identify it, we can get the treatment underway right away. And so we're hoping that that will be one of the things that parents will hear as being like, okay, this could be very helpful for my child. The second thing we're going to ask them, we're going to say, okay, the chance of your child having one of these conditions is low, but even if you're one of the 99%, because we think we're going to end up with perhaps 1,000 positives, both true positives and false positives out of the 100,000, even if you're among the 99,000, we'd like to continue to follow your child for a number of years, because we will be able to understand what happens if a child is screened positive. If a child is screened positive, a doctor will call you up, and then they'll do a follow-up test. And for virtually all of the conditions, we have a follow-up test which will give a yes/no answer. We'll do a follow-up test, and we'll be able to figure out, was your child really affected with the condition, or were they a false positive? So we're going to be able to take care of that. But for that other 99,000, we would like you to still be part of our program, to continue to let us follow your child, because we want to know when there was a false negative. We know that for the conditions that we're looking for, we're really focused on very high specificity. By choosing pathogenic and likely pathogenic variants, if a child has, say, it's a recessive condition, and both copies of the gene have a pathogenic variant, we think there's a very high probability that the child will in fact have the condition. But we also know that we don't know all the pathogenic variants. So we know that for the conditions that we're looking for, that we're screening for, we're going to miss some of those children. And the only way for us to figure out if this program is a good idea or not is to allow us, you the parents, to allow us to continue to follow your child, to also detect those false negatives. Obviously, at any point, a parent could simply say, no, I don't, you've given me the answer that my child doesn't have one of the conditions. I understand that my child could still develop one of these conditions, and that's a very important point when we're speaking to families, is that a negative screen doesn't mean you're off the hook. But if a parent said, all right, you screen my child, now I'm kind of done with your program, take my data out, we're very happy to do that. And so our goal and our idea is that we need to follow these families more long term. And we're going to tell them, look, you joined this program, we'd like to continue to follow your child, but we believe that this information about your child, whether it was screen positive or screen negative, will help other children. Again, whether you're screen positive or negative, this could help other children in the future. Just like Petrus was saying, families are often very altruistic because they want other families to have better lives for their children, just as our program is trying to help these families have better lives for their own children. And so I think that's the kind of discussion we're having. One of the reasons, I apologize for going on and on about this, but this is really central to what Genomics England is doing, absolutely central. So I really appreciate you bringing this up. We are in the mid-trimester, when we're approaching families, it's not just like hand them a leaflet and you're done. No, we want to engage them. We hope that they'll look at the leaflet. We hope they'll look at it and go and look at some of our online information. We hope that we're happy to engage them actually one-on-one with a phone call. We have a lot of mechanisms that during that second trimester where we talk to families and help them make that decision. And in fact, again, I believe that our website for this is going to go live in a few weeks, so if you just keep an eye out for this, you'll see the kinds of information that we're going to provide, and some of it is how might you want to make this decision? What are the things you should think about? Because we spent a lot of time with moms and dads who are currently pregnant, moms and dads who recently delivered, to actually develop this online material so that it was written in a way which was very understandable, but reflected exactly the kinds of questions that James brought up. Do I really want to be part of this study? So that's kind of where we are on this.
So if I could add to that, James, to your question, the key element is transparency from the very beginning. And First Steps does whole genome sequencing. And the lead argument why should you do that is that we focus that it's not a curiosity exercise in curiosity, but we have 500 diseases for which there is intervention. So would you be willing to let us look at those diseases for which there is credible intervention? Obviously, the goal is to prevent permanent tissue damage, but that's not possible always. But if there is credible therapeutic intervention which can be done in Greece, okay, would you be willing to allow your child to participate in the study? And this is what wins the argument most of the times, okay? And that's probably a cultural characteristic in that society, in the Greek society. The Greeks here in the room will appreciate what I'm saying. They are pro-health, they are interested and so on. And so that is what we find.
I just want to also emphasize Petros's point about culture and cultural sensitivity. And I think that that's one of the keys to thinking about any kind of genomic program in newborns. And one of the aspects of our choosing those trusts, I remember I was saying that we're going to start, I hadn't maybe mentioned this, we're going to start with 5 and we're going to work our way up to 40. Those initial trusts are ones where there's a great deal of diversity. And we want to make sure that we're absolutely engaging in the different minority communities, not just the Caucasian community. And our success, we believe, and we're going to be measuring our success by our engagement with these minority communities. And so it's important to sort of reach people where they are, not where we are, and be able to sort of answer their questions and relate to their communities. And so that's one of the most important aspects of this program in England. And as I think about the other programs that are part of ICONS, that international consortium, each of those programs, there are several, there's 4 or 5 in the US, there's a couple in Australia.
There are 11 altogether.
Thank you. They have each approached from a sort of a social point of view what makes sense in that society. And so I don't think it's a good idea to sort of think of this as a global program. I think we need to be very sensitive to how people in that society and that country feel about newborn screening and that information.
It's for them.
Thank you so much. We are run out of time, and Torben is looking at me. Unfortunately, we had a lot of very good questions from the audience, which we don't have time. Hopefully, we can answer online. They were mainly around the ethical issues and VOSs, and for another time. But I would like to thank you so much. I really enjoyed this. I hope our audience here and online also did. I would have carried on for the whole day talking about this, but yeah, that's us done. Thank you so much, David and Petros.